Hi, everyone, and welcome. My name is Bryn Berger, and I'm with the Priority Populations Team at the Colorado Department of Public Health and Environment, or CDPHE. And our partners at County Sheriffs of Colorado, or CSOC, are also here with us today. And we're excited to have all of you here for this webinar about common skin infections in jails. Although the title mentions jails specifically, this information also applies to other types of correctional settings. And our presenter today is Bill Calawerts, MD, Preventive Medicine Resident with CDPHE. Next slide, please. CSOC and CDPHE are partnering to provide this training series on infectious disease prevention in correctional settings. And these trainings are designed for both healthcare and non-healthcare staff. We've had 2 training sessions so far, one on tuberculosis and one on influenza and RSV, and I'll tell you how to access those on the next slide. This slide lists our upcoming sessions, and the next one in the series is Emerging Infections on Tuesday, November 14th. Next slide, please. A few webinar reminders. This training is being recorded. Please mute your microphones so that we don't hear background noise. If time permits, presenters will address questions following the presentation. At that time, you can submit questions using the chat feature here in Zoom or by clicking raise hand to speak. And within the next couple of weeks, participants will receive an email with instructions for accessing the slides, the recorded presentation, and a brief evaluation survey. The recording will be posted to the CSOC YouTube channel, and that's also where our past 2 trainings are posted already. I'll put the link to that YouTube channel in the chat, and I'll also put the training evaluation survey in the chat as well. And we really encourage you to fill out that training survey so that we can continue to improve these training offerings. And I'll go ahead and hand over the presentation to Dr. Calawerts now. Thank you.
Great, thanks, Bryn. As mentioned, my name is Bill Calawerts. I'm a family medicine physician, and I am a current preventive medicine resident who's doing a rotation with CDPHE. My residency is at the University of Colorado, and I'm excited to speak to all of you guys today. There will be time for questions at the end, so feel free to pop anything in the chat and we'll address it at the end as it comes up. Our objectives today, so I'm going to start by outlining the presentation of some of the most common and/or concerning skin infections that are found in jails. I'll help the staff recognize what some of these early signs of these infections are. Perhaps most importantly, we'll talk about different techniques to prevent transmission of these most common and/or concerning infections. And then lastly, I'll overview the treatment options for each of these infections. I wanted to start with this slide, which is a general outline from the CDC of 5 elements of how germs spread. So I want you all kind of thinking about these as we go through each of the bugs. So we always talk about reservoirs, where the bacteria lives and resides, the people who are ill, how are the germs able to survive and for how long outside of an infected host, how do they go around the body's defenses, and then what types of pathways can they enter the body to cause infection. This again is just another resource from the CDC that has an infection training toolkit. And it just kind of goes over that in general. If you're not sure what causes a rash, you should take the following precautions. So making sure that we're treating any broken or irritated skin with care, because it's a vulnerable place where these infections can enter the body. If you are someone providing care or interacting with someone with a rash, that you're wearing gloves to prevent these germs from spreading. And lastly, that we clean and disinfect things that the patient has touched if we think this may be an infective rash. I'm going to start with the most common type of rash. These are dermatophytes or fungus rashes. They're the most common skin infections worldwide, and they're caused by fungus that can infect the skin, hair, or the nails, and that's because they require keratin, which is found in all of those. You've probably heard of many of their common names like athlete's foot or jock itch or ringworm. They all, you may see their scientific names start with tinea. And one thing I just wanted to point out here too is that they're called ringworm, but they're not caused by worms. That more has to do with what the presentation can look like, and I'll get into that in a bit. In terms of the epidemiology, and this holds for most of the scientific literature that I was able to find, that it's most of the literature is from prison populations, so just note that here. But up to 60% of all prison skin infections are fungal or dermatophyte infections. They're spread through direct contact or with fomites, And interestingly, they don't affect the mucous membranes at all, so not really in the mouth or the nose. They live on humans, in animals, or in the soil. And these infections, just to point out, are usually not life-threatening or serious medical illnesses, but they can be very irritating and they spread quite easily. Risk factors for these types of infections include those who have really moist skin or sweat a lot, those who are immunocompromised, which will be a theme for most of the infections during this talk. So those any sort of cause for a weakened immune system, those with diabetes, or those who use topical steroids for other skin illnesses are more at risk for these infections. I wanted to briefly just touch on this slide from the CDC that talks about drug-resistant funguses. So kind of similar to bacteria and becoming resistant to antibiotics, funguses are doing the same. And it's just something to keep an eye on over the subsequent years, as we expect this may get worse. Here are some classic presentations of ringworm or dermatophyte infections. And just in general, to point out, these rashes are usually itchy, very itchy, but they're not painful. If they're painful, you want to maybe be thinking about a different skin infection. So the top left and top center, if you look at those are classic like tinea corporis, or of the body, and they have this circular appearance with redness or erythema. Moving to the top right, we can see ringworm, what it looks like on the scalp. So it'll be red, itchy, and hair won't generally grow in that area. You can see athlete's foot in the bottom right here. And then the bottom left is, I think, a good example of why this is called ringworm, because this rash in some cases can look like there are worms on the skin, but again, this is a fungal infection. Okay, so how can we prevent this? So as I mentioned, it really likes moist environments, so anything we can do to avoid that. So making sure people are changing their socks and underwear daily, that we use moisture wicking fabric when we can, when things are going to be sweaty. Making sure people are not walking barefoot in gyms or shared showers or pools or anything like that, and avoiding sharing towels or personal items. Those who are infected, you should both treat the infection, but also if it's a foot infection, that we're treating their shoes with an antifungal powder. And then in general, prompt medical evaluation and treating these infections is important, because those who have the infection are more likely to spread it to others. So if we're able to nip that in the bud, we can limit spread in enclosed environments. The treatment depends on the location and how serious the infection is. Usually, and most of the time, folks can just use over-the-counter medications. In some cases, they do need prescription medications, and you should contact a health provider if the infection is worsening despite using antifungal. That could be a sign that it's either resistant or it's a different type of infection, or if ringworm is on the scalp, because that's a little bit more difficult to treat and needs a prescription. Moving on to bacterial infections, I'll start with group A streptococcus, and most of you have probably heard this as the bug that causes strep throat, but it can also cause skin and other soft tissue infections. This is a normal bacteria that lives on the skin in most of us, and it's just part of the normal flora, but it doesn't always cause infections. These rashes are typically painful, as I'll get into with the presentation of it. In terms of epidemiology, about 3% of skin infections in prisons are bacterial, and the most common types of bacterial skin infections are streptococcus and staph, which I'll get into next. In some cases, these infections can become invasive, which is a very serious infection. Group A invasive strep is very serious and can have a case fatality rate of up to 30 to 60%. It's relatively rare, with only 3.5 cases in 100,000 people, but I'll outline some of the things that should make you think that might be going on. In terms of the reservoir, I mentioned it regularly lives on human skin, just in regular flora, but doesn't always cause disease. And risk factors for how people get these types of infections is any kind of skin trauma. So that can include tattooing, that can be IV drug use, or sharing needles can introduce the bacteria underneath the skin. Exposure to those who have skin infections is a risk, and then any condition that weakens the immune system. Here are some pictures of cellulitis caused by group A strep, and we always talk about 5 things that make us think this is a bacterial infection. One, is the area warm or warmer than the other side? Is it swollen or is there edema? Is there any pus or drainage coming from the wound? Is it red, which it can be a little difficult to tell in some cases, but is it darker red than normal? And then lastly, is it painful? And so these are some good examples of what cellulitis may look like. Here are some other types of infections that group A strep can cause. So in the bottom right, this would be a common presentation of strep throat. In the top left is a group A strep infection that is on the face and nose, and it's just one of my favorite medical terms, which is erysipelas. I just like saying that word, but that's what that looks like. In the middle is a infection of group A strep called impetigo, which is more common in children, and you can see some crusting and yellow there. And then in the top right, you may have heard of scarlet fever, which is more of a systemic full body rash that can be caused by group A strep and is also more common in pediatric populations. Okay, so we're talking about invasive group A strep. You may also hear necrotizing infection or toxic shock syndrome. You can see in the picture, in some cases, it looks similar to a regular cellulitis. And so you may not be clear at first that this is a more serious infection, but some things that you should be worried and thinking about this is the patient immunocompromised? So do they have an autoimmune condition? Do they have any sort of cancer? Are they pregnant? Those are all things that can weaken the immune system and make it more likely to get this infection. Have they had any major penetrating trauma? Most of the time, that means like recent surgery. Do they have any stab wounds, or including IV drug use as well? So this picture here kind of shows what necrotizing infections progress to. And so this is much more obvious than the initial picture, but clinical signs that should point you to this is, do they have really severe pain with the rash that's out of proportion to what you see on the rash? Like, is it hurting them much more than you would expect for a small rash on their body? Is the redness of the rash spreading relatively quickly? And in some of those earlier pictures, you saw lines drawn. And so that's a good way to monitor how fast it's spreading. Do they have any systemic signs like fever? Is the skin becoming black? Is it bruising or blistering? And then lastly, if any of the joints are involved, those are all signs that you should get a medical provider involved sooner than later. As mentioned, these are life-threatening conditions, and the most important thing is immediate medical evaluation and treatment to lower the risk of severe illness. So in terms of prevention of these, I like to talk about the 5 C's, that these are the things that we can help limit to limit the risk of spread. So limiting contact between people who are sick, making sure that we're cleaning the contaminated surfaces and limiting shared items, isolating the person and trying to avoid crowding, and regular maintenance of cuts and scrapes like I talked about earlier. And then lastly, what can we do to ensure that there's not a lack of cleanliness? Here is another good graphic about basic wound care. So anytime there's a break in the skin, making sure that we're washing and cleaning that area and as much as possible trying to cover it. Those can all be helpful. If you have a sign of major penetrating trauma in a person that you're taking care of or that you see, I would recommend seeing a medical provider sooner, because those can be an impetus for an infection. Treating these most of the time will require antibiotics. The earlier, the better. And we should monitor these people particularly closely in the first 24 to 48 hours after antibiotics were started. If the patient's not improving with antibiotics, that could be a sign that it's resistant or that they have a more severe infection going on. In those cases, hospitalization may be required for IV antibiotics and more monitoring. Okay, I will now move on to MRSA, or methicillin-resistant Streptococcus aureus. I'm sure many of you have heard about this. It has been in the news more as it's becoming more common, but it's a very common type of bacteria that, again, lives on most of our skin, but in some cases it can cause any type of infection. So skin infections, pneumonia, bloodborne infections, all of those. And why this is particularly dangerous is because it's resistant to several types of antibiotics. It's more likely to cause abscesses or boils or pimples than strep, and oftentimes patients will complain of having been bit by a spider. And lastly, if this is untreated, it can become a very serious and systemic infection. One thing I want to point out is that a lot of us do carry this on our skin, but it doesn't always cause infection. It needs some sort of impetus to cause that infection. All right, in terms of epidemiology, the studies have shown about 5% of patients in the hospitals are carriers of this. They're healthy, they don't have any symptoms, but they carry this type of bacteria. Alarmingly, this has been increasing steadily in the US and worldwide over the last 10 years, but particularly in prison populations, the rates are anywhere between 20 to 85% are carriers. Again, most of the data I found was from prisons, but and it's kind of a wide range, but regardless, that's still much higher than the regular population. The CDC estimates that MRSA is responsible for more than 70,000 severe infections a year and over 9,000 deaths. The reservoir, like I discussed, is humans, and it's either on the skin or most commonly, and we can check for carrier status by checking if the bacteria is in the nose. Risk factors for MRSA, those who use injection drugs, those who are colonized, again, folks who have a weakened immune system, those who are experiencing homelessness, and those who are in correctional facilities are at high risk for these infections. So when you should be concerned about MRSA, often the same 5 things that we discussed with regular cellulitis. So is it red? Is it painful, warm, swollen? And then I will highlight that pus is more common with these types. So yellow or greenish fluid, sometimes foul smelling can point to that. Abscesses or boils are also more common. If folks have systemic symptoms, that can be a sign that the infection is more severe. So fevers, their heart rate's higher, low blood pressure require immediate medical evaluation. Also, those who have been recently in the hospital or have been on other antibiotics are also at risk for these infections. Here's a slide just outlining how much more at risk those who use injection drugs are for MRSA infections, and it's estimated over 16 times more likely to develop invasive MRSA infections, which are the severe infections. So if that's a characteristic of population you're serving, to keep an eye out on that and be thinking about MRSA. Here are some pictures of what a MRSA infection may look like. The 2 on the right here are common abscesses or pimples, boils you may hear. These rashes, again, these are painful. They're usually not as itchy as much as people are complaining of pain. These can spread really easily, especially in shared surfaces. And so they can spread through touching the infected person, through the pus if people are trying to drain these on their own, or if that pus gets on any surfaces, it can live for a while. These include personal items like razors, clothing, towels, bed sheets, anything like that. And then they're particularly prominent in shared common spaces like in gyms, the doorknobs, dorms, all of those things. This graph on the right is an example of a MRSA outbreak in Mississippi correctional facilities. And you can just see how over time it grows rather exponentially if it's not taken care of. I'll bring up the 5 C's again here because it's really the most thorough way to limit transmission. So how are we limiting contact with those who are infected? How are we cleaning our contaminated surfaces? And I'll specifically say gyms, dorms, etc. for this. Limiting crowding or isolating those who are infected, regular wound care and keeping an eye on wounds before they get out of hand, and then a general lack of cleanliness, the risk. So to treat these will most of the time require antibiotics, and if there is an abscess, a boil, or a pimple involved, it often will require incision and drainage by a professional. I'd like to bring up that we shouldn't encourage people to pop these on their own, or if you're not trained, I wouldn't pop these as that can deepen the infection. So it's and or spread it to other people. Close monitoring is really important, just like with the last cellulitis cases in the first day or 2, to make sure that the infection is getting better. And in some cases, hospitalization can be required. All right, moving on to away from bacteria, I'll talk about scabies next, which I'm sure some of you have heard of. This is an infestation caused by a skin mite that burrows underneath the skin and lays eggs. The most common site of this is on the hands in between the webs of the fingers, but it can be on the wrists and the armpits as well. There are over 300 million infections of scabies yearly worldwide. The prevalence in North America is relatively low compared to some other areas, but still between 0.2 and 0.7%, which is not insignificant. And rates are 4 to 5 times higher in prisons than in the general population. It can spread very easily. Reservoir for scabies is humans, animals, or rodents. And risk factors, overcrowding is a big one, such as facilities like prisons, jails, or long-term care facilities, and then poor hygiene or those who are experiencing homelessness are at higher risk as well. Here are some common pictures of what scabies can look like. The most common first symptom that you'll hear is very, very intense itching. These are really, really itchy lesions. Most of the time that they're on the hands, like that picture on the bottom, and often in between the webs of the fingers is where it's most common to see them. The rash can be pimple-like. It can also have wavy lines. That depends on the body's allergic reaction to it, which causes the itching to be so severe. This is an example of crusted scabies. This is a much more severe case of scabies and represents a more aggressive and severe manifestation than non-crusted scabies. Like in the previous pictures, this we need to really treat well and make sure that we're treating contacts as well, because it means it's been going on for a while. To prevent scabies, regular hand hygiene and hygiene in general is important. Avoiding skin-to-skin contact because this is quite contagious. Also with clothes or bedding of those who have scabies. And the CDC has some pretty strict protocols that I've linked here that you can follow for single cases, and then they have more severe protocols for crusted scabies as well, just because of its increased risk of infectivity. You can, think about screening new intakes for those who have unexplained rashes or if they have really pronounced itchiness. Interestingly, so the first time someone gets scabies, they usually don't have any symptoms, and symptoms can take anywhere between 4 to 8 weeks to develop. So if you're starting to see cases pop up, that usually means this has been going on for a while. They can still spread scabies when they're not having symptoms. So again, this is just something, if you are seeing symptoms, that means that it may be worse than you think. Treatment of scabies requires a prescription from a medical provider. They need to leave the treatment on for the full course, not just when they start feeling better, or it can come back. These need to be treated very aggressively because they can spread like wildfire in institutional settings. Anyone who's had skin-to-skin contact with a person who had scabies is a good candidate for prophylactic or preventive treatment, and their close contacts that they've had as well, better to be safe in those cases. Very importantly, and this is outlined in the CDC protocols, bedding, clothing, towels, any sort of linen used by the people with scabies or in their shared settings during the 3 days before treatment need to be decontaminated. So that can be sealed in a closed plastic bag for over 72 hours or dry cleaned or cleaned thoroughly. Okay, next I will talk about syphilis, and I'll be specifically talking about syphilis from the skin and body rash that's associated with it instead of most of the other symptoms or any of the genital rashes that can be caused by syphilis. And syphilis is a disease that really can affect the entire body. It has different stages, and symptoms kind of depend on what stage it's in, which is why it's so important to catch it and treat it. There has been a huge rise in syphilis cases throughout the United States, but particularly in Colorado. And this graph on the right here outlines the increase in syphilis cases in jail and prison settings in Colorado over the last 5 years. And there's been almost an 800% increase, which is very notable. The only reservoir for syphilis is humans, and it spreads from person to person by direct contact with a syphilis sore, usually during intercourse. That can be during any type of sexual intercourse, so it can spread during vaginal, anal, or oral sex. Those who are pregnant with syphilis can transmit this infection through the placenta to their unborn child, and that can cause some severe manifestations as well. Here are some classic body skin rashes that are associated with syphilis. The most common thing that you'll hear about is a rash that infects the palms and the soles. So you can see here it's kind of an abnormally appearing rash, but most rashes will actually avoid the palms of the hands or the bottom of the feet. So if it's involving that, it's something to think about. Clinically, syphilis is a great imitator and can look like many different other rashes, like this picture here on the right. It's not totally clear. So if you're not sure, it's better just to screen for it and to check for it. It's a simple blood test to do that. Again, just outlining how much syphilis has been increasing in the United States. And I'd like to bring up that screening is so critical to this because some people can have zero symptoms from syphilis. And if we're able to catch those cases, we can prevent the spread, which, this disease can affect the brain, it can affect the heart, the nervous system, et cetera, and cause some serious manifestations. And also promoting safe sex practices, condom wearing, et cetera, can help prevent the spread of this. This is totally curable with antibiotics, and treatment, unfortunately, may not undo damage that's been done prior from the infection. If it's already spread to the heart or the brain, you will stop the infection, but you may not reverse the damage. Again, treating those who are of childbearing age or those who are pregnant is super important to prevent it from spreading to their fetus. Okay, wrapping up here, I'll talk about 3 skin infections you've probably heard of. They're less common, but still just want you to be aware of and the things to look out for them. I'll start with Mpox, which was formerly known as monkeypox, now Mpox. It's a very similar virus to that of smallpox. It's really rare, but it can be serious and fatal. In May of 2022, a global outbreak for Mpox was declared, and cases in Colorado have decreased significantly since the height of the outbreak since 2022, but is still circulating in the United States. Here's a graph outlining what Mpox cases have done over the last several months, and you can see that it peaked in mid to late 2022, and cases have significantly declined since then. Here are some pictures of what Mpox looks like. So it can really be on any part of the body. It can be with, little pustules that you see here. These can be itchy, they can be painful. One thing that kind of separates it is that it is usually associated with some flu-like illnesses or respiratory symptoms. But again, not always. It's a harder diagnosis to make, especially because it's so rare. So a good rule of thumb is if you see a rash, you're not totally sure what it is, it's always better for them to just be evaluated by a medical provider. Preventing this, it's just pointing out that it's transmitted from person to person with those who have close contacts. So that can be touching the sores or bumps. Sexual activity is a common way that this can be spread. But brief interactions without physical contact with someone who had Mpox, it's very unlikely that that would result in you getting the virus. There is a vaccine available that can help lower the risk. And so those were given during the height of the pandemic to those who were at high risk. So it's something to keep an eye on as well if there is a bump in cases. Okay, moving on to varicella. You've probably heard this referred to more often as chickenpox or shingles. It's the same virus and it causes both of those infections. Chickenpox usually affects children, but it can affect adults. It's usually a milder illness, but for those who are immunocompromised, can be relatively severe. Shingles is the reactivation of that virus long after chickenpox has gone away. That can result in severe pain, in some cases, issues with the nerves as well. Rates have plummeted since universal vaccination. Vaccination has been very effective about lowering cases of varicella. But of note, 14% of outbreaks in the US since 2010 have occurred in jails or prisons. Here's an example of what varicella can look like on the skin. So usually it's vesicles or these spots on the skin like blisters. They're in different stages of healing, as you can see. So some may have scarred over, some may have fluid in them, some may not, and that's usually cause. They can be painful, but most of the time they're very itchy. That kind of points you more towards chickenpox. If they're very, very painful or like a burning like pain, it's often what I'll hear with shingles. So to prevent this, as I mentioned, the most common and effective and safe way to do this is through vaccination. So in the United States, we generally add this in the regular pediatric vaccinations, but if any of your patients or people that are in your care are from other countries, they may not have been vaccinated. Isolation protocols are important for those who do have symptoms. The rash should be covered. Encourage them to avoid touching or scratching the rash. That makes it more likely to spread, and washing their hands over 20 seconds, and anyone who's had contact with them as well. Contact should be avoided until the rash has fully scabbed over, and especially for those who are pregnant, young children who are not vaccinated yet, or people who are immunocompromised. It's very important to avoid contact with these folks. That also goes specifically for premature low birth weight infants who haven't had a chance to be vaccinated yet. Picture on the right here, there is a vaccination for shingles that can lower your risk if you have had chickenpox in the past of shingles reactivating. Okay, lastly, I will briefly touch on measles or rubella. This is one of the most contagious viruses known to man. It's so contagious that if one person has it, 9 out of 10 people of all ages around them could become infected if they are not vaccinated. Usually folks will have fever, they'll be very fatigued, their eyes will be red, they may have a cough, sore throat, and similar to chickenpox or varicella, vaccination is part of the recommended immunization schedule. When you should be worried about this and those who are at particularly high risk for measles complications are children who are younger than 5 years of age, adults who are older than 20, those who are pregnant are at high risk for complications for themselves and the fetus that they're carrying, people with compromised immune systems, as I've talked about earlier, and if there's an unknown vaccination history for the patient and or that they've traveled to an endemic area where measles cases have been higher. There can be severe complications that require hospitalization. Can cause an inflammation of the brain. It can cause pneumonia or infection of the lung. I mentioned significant complications during pregnancy, and in some cases, it can even cause death. Here are some pictures of the measles rash. It usually affects the whole body. These people look sick. These people have other systemic symptoms when they have this. They'll not just have the rash and that's it usually. So here are just some common pictures that should make you think of it. Preventing measles, community-wide vaccination, again, it's the most effective way to do this. All children should be vaccinated against measles. I mentioned it's a vaccine that's been extensively proven to be safe, effective, and is very inexpensive. And then those who do have the infection should be isolated to limit transmission to other people who are at risk. Here are some of the sources that I used for our presentation today. I want to thank you guys all for your time. I appreciate being able to speak with you, and I have some time for questions if anyone has questions.
Thank you so much for that excellent presentation. If you have questions, you can put them in the chat box, or you can raise your hand and speak if you'd like to ask a question. While we're waiting for folks to type in questions if they have them, you mentioned on the dermatophyte slides, I believe it was the epidemiology slide, you mentioned fomites being involved in transmission. Some folks on this call might not be healthcare providers. Can you explain what a fomite is?
Yeah, sure. So fomites are basically trying to think of the best way to say this in lay terms, but a version of the fungus that's not the actual fungus, but can live on surfaces for a long time. Maybe a good analogy is like a seed. It's like a seed of a tree that can live for a long time without being in an infected host. But if it's not cleaned, it can live on surfaces and then infect people.
Thank you. Does anyone else have a question? If you do, you can type it in the chat box or raise your hand. I'm also going to put in the chat again the CSOC YouTube channel where the training recordings will be posted. And I'll also link again the training evaluation survey. We really appreciate your feedback and input on the presentations we've had so far and helping us improve future trainings. And we also are looking for one more training topic. So you can fill out that survey if you have any ideas for us, anything you'd like to hear about. And Radhika put in the chat the fomite response there. Any questions? Okay, not hearing any. So again, this is being recorded. It will be posted. And thank you again to Dr. Calawerts and to CSOC and to all of you for attending today. Have a great rest of your day.
Thanks, everyone.
Thank you.